Hey everyone, welcome to my presentation. My name is Cody Gassmann. I currently work in the Surgical Neuro Intensive Care Unit, also known as the SNCU, at the University of Iowa Hospitals and Clinics. Prior to working in the SNCU, I worked on an intermediate step-down unit that focused on neurosurgical and neurology patients. So in combination, I have 8 years experience in the neuro world, so I am extremely excited to get to educate on this topic. A little fun fact about me, I'm currently enrolled in the Mount Mercy's master's program. I'm trying to get a master's in education. So educating people is kind of a passion of mine, and neurology is a passion of mine, so I get to combine both of these in this presentation. I tried to provide a decent overview, but the neurologic system is extremely diverse, so it was very difficult to pick the most important topics. So just a kind of disclaimer, this by no means is an exclusive explanation of the neurologic system. In fact, there is so much more to learn about this system, and I encourage you all to do research after this presentation. My objectives for this presentation are to define the importance of cost, volume, and impact of the neurologic disease on the U.S. population, provide the listener with a comprehensive overview of anatomy and physiology of the neurologic system, help the listener better understand the importance of appropriate assessments on the neurologic patient, help the listener identify how different tests are used to evaluate the neurologic system, understand the pharmacological treatment of neurologic systems, and help the listener describe the care of a patient with an ischemic stroke. Throughout this presentation, a lot of diagnoses and other medical topics will be talked about, but starting with basic information is really important. So why do we care about any body system in healthcare? That's because of three main things: cost, volume, and the overall impact it has on us. It is estimated that neurologic-related diseases cost the U.S. $800 billion a year. The top three most common neurologic problems are, first, Alzheimer's and dementia-related diseases, costing $243 billion a year, chronic back pain, $177 billion a year, and then stroke, which is estimated to be about $110 billion a year. Looking at volumes to determine how prevalent neurologic issues are were really just difficult, and so I decided to look at stroke, which in the US every year, 795,000 people suffer a stroke. So what is the impact that has on us? Neurologic disease impacts 100 million Americans per year. We are going to start by getting into some anatomy, and we're going to start at the very beginning, going back to the basics and looking at cellular physiology. The most important cell found in the neurologic system is called a neuron. A neuron is defined as a nerve cell responsible for receiving sensory input from the external world and then sending electrical signals, also known as motor commands, to our muscles. There are multiple types of neurons found in the neurologic system. Some say there's up to even 10,000 neurons found, but we work with three main ones. The first one is a motor neuron, which conveys motor information. The second is a sensory neuron, which conveys sensory information. And the third is an inner neuron, which conveys information between different types of neurons. As mentioned on the slide, electrical signals, also known as action potentials, are responsible for communicating with other neurons. This is due to electrical signals traveling the length of the axon and causing release of neurotransmitters into the synapses, which is a space between the terminal axons of one neuron and the dendrites, which then receive neurotransmitters. The action potential and transmitters release allow the neurons to communicate with each other and other neurons. Next, we're going to dive specifically into anatomy and physiology of the neurologic system. We will start by discussing the central nervous system, frequently referred to as the CNS, which is composed of three components. First, the brain, then the brainstem, and the spinal cord. We will then discuss the peripheral nervous system, also known as the PNS, which consists of neurons outside of the three main CNS systems. So starting with the brain, it is composed of four main lobes, each with very specific functions. The first lobe is the frontal lobe. The frontal lobe is used for executive functioning. It does things like emotional regulation, planning and reasoning, and problem solving. Every time I think of the frontal lobe, I think of frontotemporal dementia, which is a very rare type of dementia, but when you have it, your frontal lobe begins to shrink and your family members start noticing that you act irrationally. That's typically what brings you into the doctor. to get that diagnosis. The next lobe is the parietal lobe. The parietal lobe is known for integration of sensory information. It typically does touch, temperature, pressure, and pain. The third lobe is the temporal lobe. This processes sensory information. Usually this is done with hearing, recognizing language, and forming memories. The final lobe is the occipital lobe. This is located at the posterior of the brain, and it is the visual processing center of the brain. When learning about the brain, it is really important to learn about brain vasculature. Toward the end of this presentation, we will be going through slides that break down a specific neurologic disease. The disease will be an ischemic stroke. If you look towards the right side of this slide, you will see several arteries joining each other, which is called the circle of Willis. This is found at the base of your brain. This supplies blood to all of your brain. When a stroke occurs in your brain, hemiparesis or hemiplegia occurs on the opposite side of your body. This is due to something called decussation of pyramids. Decussation of pyramids is the juncture between the medulla and the spinal cord where motor fibers cross to the opposite side of the body. This means when a stroke physically occurs on the right side of your brain, it'll travel down the motor cords and it will actually affect the left side of your body. And just a fun fact about brain vasculature, the middle cerebral artery is the most common artery to be involved with a stroke. The next part of the central nervous system that we're going to talk about is the brainstem. The brainstem is composed of three main anatomical parts: the medulla, the pons, and the midbrain. The medulla oblongata, which is light orange, connects the brainstem to the spinal cord. It also contains the nucleus of solitary tract. This tract receives information about blood flow, including information about levels of oxygen and carbon dioxide in the blood, heart, and major blood vessels, and then reflexively corrects numbers by working with the cardiovascular and respiratory systems. The medulla is also essential for survival. Next, we have the pons, which is light blue. The pons is the home of multiple cranial nerves, typically cranial nerves, which we will go through on the spinal section, that do with touch, temperature, pain, and eye movement. And lastly, the midbrain, which is light green in this photo. This helps with motor movement, eye movement, and auditory and visual processing. The final part of the central nervous system we're going to talk about is the spine. The spine consists of 4 different types of vertebrae. The first is the cervical spine, and that would be C1 through C7. And the cervical spine is used to support the skull and provides mobility to the upper spine. The next is the thoracic spine, and this is T1 through T12. This protects your heart and lungs and holds your rib cage in place. The third one is your lumbar vertebrae, which bears the weight of the body, and it is L1 through L5. And finally, the sacral vertebrae, which connects the spine to the iliac bones, and these are 5 fused vertebrae together. During the assessment part of this lecture, we will discuss the levels of the spine and the function of each level in dermatomes, which are that look at sensation of the spine. Now that we have talked about the brain, brainstem, and spinal cord, we are going to transition to the peripheral nervous system, also known as the PNS again, which consists of 2 main components. The PNS consists of sensory or afferent neurons and motor or efferent neurons. The afferent neurons are pretty easy. They just carry nerve impulses from the sensory stimuli toward the central nervous system. So they would carry those nerve impulses toward the brain. The efferent neurons, which are broken down to 2 more divisions, use motor neurons to carry neuronal impulses away from the central nervous system, so they use motor movement to get away from items. The 2 divisions that the efferent neurons have are the autonomic nervous system and the somatic nervous system. The somatic nervous system is a lot easier than the autonomic nervous system in that it just controls voluntary movements. The autonomic nervous system, again, is divided into 2 more subparts called the sympathetic and parasympathetic divisions. The sympathetic nervous system is known as your fight or flight response. It does things like dilate pupils, bronchodilates, stimulates epinephrine and norepinephrine release, inhibits stomach, pancreas, and intestine movement to preserve blood during non-ordinary situations, so that blood can be shifted to more vital organs. Whereas the parasympathetic nervous system, it's more for conservation of energy. It's the rest and digest state. Both the sympathetic and parasympathetic nervous systems work together to try to ensure as much safety for your body as possible. So now that we have talked about anatomy, we are going to move on to the assessment of neurologic patients. Assessments are extremely important in neurologic patients because it catches even minor changes very, very quickly so that we can get new CTs or just doctors there to see what's going on with the patient sooner. So the first important part of an assessment on a neurologic patient is the mental status assessment. This is typically done by orientation level. So a lot of times we say oriented times 3, which is person, place, and time. They can be oriented times 2, which means they're only oriented times 2 of those topics, and so on. The next part of a mental status exam is if they're making sensical speech. So are they making sense? Are they confused? Are they delirious? And then finally, are they aware of their interactions that they're having with people? Next on a neurologic assessment would be a motor function and balance test. So a lot of our patients, we will ask them to do push-pulls with their hands and their feet during a neuro exam. And then if they are able to get up and out of bed, we will have them try to stand on both of their feet and then try to balance on one foot and then try to balance on the other foot. A lot of times we will do these exams and then we will actually redo these exams with the eyes closed to see how aware of spatial awareness that they are. And finally, the spinal cord. Spinal cord assessments are so important for every neurologic patient. It really helps guide physical therapy and occupational therapy on what type of therapy they're going to do. And it can be something that nurses don't think about is it can just really help guide even the use of silverware. Do we need an adaptive device or can this person use a normal fork? Can they shrug their shoulders and get their hand to turn inward so that they can use that adaptive device? And so a lot of times occupational therapists lean on us to help make those decisions. Next, if you look towards the right side of this screen here, you will see a depiction of the dermatones that we assess. Typically, we do hot, cold, and sharp, dull on dermatones, and you can see that there are a lot of dermatones. We typically try to do a full spinal assessment on spinal patients every 8 hours, but we will like to do 2 sites, 2 vertebrae above and below the site of injury at least every 2 hours to make sure that that injury is not progressing and that we wouldn't catch it. This slide is a continuation of the important assessments we can do on neuro patients. It includes reflexes, cranial nerve evaluation, coordination exams, cognitive or memory assessment scales, and constitutional examinations. So starting with reflexes, typically adult reflexes are done with the reflex hammer, but newborns and infants have a lot more exciting reflexes that we test. So the Babinski reflex is if you stroke the inside of a baby's foot, the toes will extend upward. Fun fact, we grow out of this within the first couple months of life. And then if we admit a patient that is not doing well neurologically and we stroke their inner foot as an adult and they do the upward motion with their toes, it's actually a sign that the patient is having negative spinal reflexes and will potentially have brain death or herniation occur. And so it's actually something that we look at in the adult world too. But it's just the Babinski's reflex is normal for newborns, but a very negative sign for adults to actually have. A couple more fun reflexes that newborns or infants have are the Monroe reflex. It's also known as the startle reflex, which is when a quick change in the infant's position will cause the infant to throw their arms outward, open their hands, and throw back their head. And another type of reflex that infants have are the plantar grasps, which is when you put your finger into an infant's hands and they naturally curl their fingers around your finger. The next assessment is the cranial nerve evaluation. There are 12 main cranial nerves. For the purpose of time, I'm just going to go through a couple ones and then what we would expect for the patient to be able to do and what we would ask them to do. So the first one that is common is the olfactory nerve. This is the nerve that helps with smell. The patient would be asked to identify different smells with their eyes closed. We'll go to cranial nerve 3 then. It's the oculomotor one. This is the nerve that is responsible for pupil size and certain movement of the eyes. And the healthcare provider typically examines the pupil with a light to see if the pupil is constricting appropriately. We'll skip to the fifth cranial nerve now, which is the trigeminal nerve. And this nerve allows for many functions, including the ability to feel the face inside of the mouth and move the muscles involved in chewing. So the healthcare provider a lot of times will touch the patient's face in different areas and see if they are able to bite down appropriately. The next cranial nerve that we can talk about is cranial nerve 8, which is the acoustic nerve. This is the nerve that is used for hearing. A lot of times the provider will just do a simple hearing test, whether it's just rubbing their fingers together next to the patient's ears to see if they can hear that noise. Cranial nerve 9, which is the glossopharyngeal nerve. This nerve is involved with taste and swallowing. And so in this one, providers may ask the patient to identify different tastes in the back of the tongue, and they actually might test the gag reflex of a patient with this one. Cranial nerve 11 is the accessory nerve. This nerve is involved in the movement of shoulders and neck. And so for this one, a lot of times providers will ask the patient to shrug their shoulders and then try to look side to side with mild resistance being provided. And then the final cranial nerve 12 is the hypoglossal nerve, and this is responsible for tongue movement. And so the patient may be instructed to stick their tongue out and try to speak to the provider when being examined. Next up is the coordination exam. There are many ways to test coordination exams on patients. A lot of times I see this one with the finger to nose with your eyes closed. So it would be as simple as asking the patient to hold up their 2 pointer fingers, close their eyes, and then point their right finger and touch their nose and remove it, and then use their left finger and touch their nose and move it. And it's a pretty good depiction if they are coordinated or not. The next one up is the cognitive and memory assessment scales. Below, at the bottom of the slide, you will see a lion, rhino, and camel. This is taken from a dementia Alzheimer's screening form, and it helps. So what they do is they ask the patient what animals that they see, and they get a check mark in the little box next to the animal if they get it correctly. It just does more of a memory assessment test for them. And then finally, the constitutional examinations that are performed on neurologic patients, which would be things like blood pressure, heart rate, respiratory rate, and temperature. And people maybe don't realize how important these are to the neuro system, but things like blood pressure and heart rate help to perfuse the brain specifically. And then respiratory rate is important because it helps oxygenate the brain. And finally, temperature management is extremely important in these types of patients because an increased temperature actually causes the brain to have an increased intracranial pressure. But a decreased temperature can actually cause shivering, which also causes increased intracranial pressure. Next up on the assessment of neurologic systems is tests and evaluations. So there are multiple types of tests and evaluations that we do on neurologic patients. Some that come to mind, and this is definitely not an exhaustive list because there are so many different types of tests done on neurologic patients, it was hard to come up with a solid list on it. So the first I did was a CT scan. This is kind of our standard because it's a quick look at the brain. And it just combines a series of x-ray images taken from different angles around your body, in this case your brain, and then it just does cross-sectional images so that we can get a quick look at it. The next one is what we call a CTA. This is important if we think anybody has an aneurysm because it injects contrast dye for the CTA into the blood vessels, so it shows us what's going on in the vasculature of the brain. Next up is your MRI. These are important because they give us a very detailed image as to what's going on in the brain. So a lot of times these will be used on new tumors in the brain, or if we're trying to just figure out something very specific in the brain as to what's going on. The next item that I wanted to discuss was something that we call EEG. This is electrodes that are attached to the scalp to record electrical activity. If we have somebody that is having seizures, we will do this. EEG can be put on as like a spot check, so just for a couple minutes to see, or it can be something that we do for the long term, for like many days on patients to see how many seizures somebody's having, or we utilize it if we think somebody that is having status seizures so that we can treat those seizures quicker than we would normally recognize them. Next up is something called a lumbar puncture. This is done by using a spinal needle. It is placed into the spine to usually measure intracranial pressure to see if that is a normal range, which is 0 to 20, typically actually 10 to 20. And then you can also obtain spinal fluid to see if somebody has meningitis or any other type of infection in their spinal fluid. And finally, a device that we use is an intracranial pressure monitoring device. So internally, we use something called a ventric. These are important because when your ventricles say that you have a bleed in your ventricles, a lot of times those ventricles get clogged up with blood, and so your body actually needs help removing that spinal fluid because it's not absorbing it into your system. So the ventriculostomy, we utilize that to drain spinal fluid out of your brain so that you don't have that swelling occurring. That system that we use is transduced so we can see the number. Again, the number that we like to see is anywhere between 0 to 20. And then if we don't have the internal ICP device, we will use an external one called a bolt. This also gives the same readings, but it's a closed pressure on that patient. The next part of this presentation is going to go through the pharmacology of neurologic patients. Again, this is not an exhaustive list because neurologic patients are on so many different types of medications. The first one that I wanted to talk about are anticonvulsants. So this would be like Keppra or phenytoin, also known as Dilantin. This is typically used to treat seizures. There are a million different types of anticonvulsants: Tegretol, Migdol, Topamax, phenobarbital are some common ones that I can think off the top of my head. And the pharmacokinetics on these ones are suppression of excessive rapid firing of neurons. Typically, this is done by using sodium channel blockers, GABA inhibitors, and glutamate blockers. The next medication would be antihypertensives, and this would be your metoprolol, lisinopril, and again, there's an insane amount of other type of antihypertensives that neurologic patients could be on. And again, these are just used to treat hypertension. And the pharmacokinetics of this is it typically produces vasodilation. And it does this in many different ways, but a lot of them block against the formation of angiotensin II. They will either block beta-1 and or beta-2 receptors. And then the final drug that I'm talking about on this slide is going to be your thrombolytic, which in neurologic patients is typically something called TPA. And it is used to treat stroke patients, and then also can treat patients with MIs or myocardial infarctions. And the pharmacokinetics of this is that TPA binds to fibrin surfaces, also known as clots, and converts plasmagen to plasmin, which essentially just liquefies the clot. Pharmacology for neurologic patients continued, starting with NSAIDs. So NSAIDs are typically used to help get some pain relief. You will see that physicians are very hesitant to prescribe narcotics or opioids to patients with neurologic problems because they don't want them to get too sedated or sleepy, because if they do that, then they will end up getting a stat head CT to see what's going on with them. So the pharmacokinetics behind NSAIDs typically is they inhibit COX-1 enzymes that produce prostaglandins, which are involved in inflammation of the body. Next up are your statins. So this would be like your Lipitor or simvastatin. And the disease that these treat would be your hyperlipidemia or increased cholesterol. The pharmacokinetics behind this is it blocks conversion of HMG-CoA to mevalonic acid, which in turn increases your cholesterol. And lastly, the last drug class I want to talk about are anticoagulants, and this is stuff like heparin and warfarin. And the disease that it treats is clotting disorders, and it helps just thin blood due to any other types of cardiac issues. So the pharmacokinetics of this is it suppresses the synthesis or function of various clotting factors down that clotting cascade. Now that we have talked about anatomy and physiology, assessments, tests and evaluations, and pharmacological treatment of neurologic patients, we will put it all together to do a disease presentation on ischemic strokes. So the pathophysiology of ischemic strokes, typically vessel occlusion, is primarily due to complications of a cardiovascular disease or a cardiovascular event. These can include hypertension, atherosclerosis, hyperlipidemia, and dysrhythmias. I find that a lot of patients that have had an ischemic stroke do have AFib, whether it is chronic AFib or intermittent AFib. When we go to do an echo on their heart to see what is going on, they'll usually have a clot in there, and then we will also catch some AFib on an EKG. So the anatomy and overview, ischemic strokes can happen anywhere throughout the vasculature of the brain, but as we said earlier, the middle cerebral artery is the most common place to have a stroke. In etiology, so where are these strokes coming from? Typically a blood clot or plaque. Like I mentioned earlier, if you go into AFib and your heart quivers for a little bit, you can get a blood clot to form, which is then shot up to your brain, or then plaque. So if you have hyperlipidemia and some plaque breaks off of a vessel, it can also get shunted up to your brain. So testing wise, for patients specific to ischemic strokes, if you come into any type of emergency department and you think that you are having an ischemic stroke or you're an inpatient in a hospital, the first thing that they will do is check a blood sugar. This is because hypoglycemia can actually mirror the signs and symptoms of a stroke, and they would hate to do unnecessary tests like a CT scan or give you medication just because they need to give you a little bit of sugar in your body. So after your blood sugar is within normal range, they will do a CT scan. The reason that they do a CT scan is they are very quickly trying to see if there is blood on that scan. So they're looking for the white on the CT scan, and if they do not see that on the CT scan, they are going to, it's a presumptive test. They are going to assume that you actually do have a clot in your brain that they are unable to see. And this is when they will give you TPA. Moving on to treatment of ischemic strokes, on the previous slide I had mentioned that TPA would be the drug of choice in hopes to dissolve that clot, and another option can happen called a thrombectomy, and this can be done either through an artery in your wrist or an artery in your groin, and a physician will actually use a camera to go up and try to remove that clot from the vasculature in your brain. And it can be in combination. You can get TPA and get a thrombectomy. And certain patients do get that, and it's extremely successful. So evaluations for ischemic stroke patients would be neuro checks that are very, very frequently. Per the American Heart Association guidelines, if you get TPA, your neuro checks have to be very, very frequently at first, and then they slowly start spacing them out. A lot of times we will do a post-intervention CT to see how the brain looks to make sure that there's no damage occurring or any new damage occurring. And then after you get a thrombectomy, you will have brain site checks, or what we call post-angio checks, to make sure that you don't have any bleeding, since they're actually going through an artery in your brain or your wrist. In long-term treatment of these patients, they typically are put on some type of statin, antihypertensive, and then they are seen by physical therapy, occupational therapy, and speech therapy. And unfortunately, a lot of these patients do end up in some type of rehab facility. In conclusion, I believe that my objectives were met for this presentation. We did define the importance of cost, volume, and impact of neurological disease on the U.S. population. I provided the listener with a comprehensive overview of anatomy and physiology of the neurologic system, helped the listener understand the importance of appropriate assessments of neurologic patients, identified how different tests are used to evaluate the neurologic system, helped the listener understand pharmacological treatment of the neurologic system, and then we described the care of a patient with an ischemic stroke. If you have any questions regarding this presentation or the neurologic system at all, please feel free to reach out to me with the email provided on this slide and the phone number provided on this slide. Like I said earlier, the neurologic system is definitely something I'm very passionate about. It's what I've known since I became a nurse, and education is also something that I'm very passionate about. So if there's any way at all that I can help guide you in your learning on the neurologic system, please let me know. I hope you enjoyed the presentation. Thanks. Now that you have watched my presentation on the neurologic body system and become an expert neuro nurse, I thought I would post the case study on the PowerPoint slide also, in case anybody didn't have access to it on Brightspace. I'm in Group A, and so if you're part of Group B and you want to do it, more power to you, but I just wanted everybody to have access to the case study. I did mirror the disease presentation of the ischemic stroke on my PowerPoint presentation for my case study, because I find value in teaching something, letting somebody hear it, explaining that topic, and then asking them questions on it. And I think it's a good opportunity, since you guys can pull up the video while you're going through the content of ischemic strokes in the presentation case study. So if you have questions on why blood sugars are taken or why there are MRIs done and stuff like that, you were able to look back on the information on my slides specific to ischemic strokes. So I hope you enjoy the case study, and I will give you a minute here to read through the content.